Hi, welcome to the JOMA Preventative Health Podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and the co-chair of the JOMA, Jewish Orthodox Women's Medical Association Preventative Health Podcast. And I'm really excited and really honored to be here today with Dr. Margo, and I'm not sure how to pronounce her name, Thienemann?
It's close, Thienemann.
Thienemann, I meant to ask before. Dr. Margo Thienemann, beautiful name. Hi, thank you so much for joining me.
You're welcome.
Dr. Thienemann is a co-founder and director of psychiatric services at the Immune Behavioral Health Pediatric Acute-Onset Neuropsychiatric Syndrome, also known as PANDAS or PANS. I should actually differentiate PANS, which is the Pediatric Acute-Onset Neuropsychiatric Syndrome, from what people are more familiar with the term PANDAS, which I think actually stands a little differently for Pediatric Autoimmune Neurodevelopmental Disorders Associated with Strep, which was the original diagnosis.
It's clear why we have acronyms.
Yes, right. People are used to PANDAS. That's why I want to say this, but I also want to say we're going to be talking about PANDAS and PANS. I'm going to let you get into that in just a minute. I want to give the rest of your really impressive bio and story. The clinic is the first PANS clinic in the country. Dr. Thienemann is an author and contributor to many PANS publications, including the PANS Consensus Treatment Guidelines and PANS Clinical Management of Pediatric Acute Onset Neuropsychiatric Syndrome, Part 1, Psychiatric and Behavioral Interventions. She has also written Seeing Your First Child with PANDAS PANS, along with the PANDAS Physicians Network, Diagnostics, and Therapeutics Committee, and with Stanford Continuing Medical Education, a free online CME activity, Presentation and Early Management of PANS, which is highly recommended. And I went through at least part of that. So there's both an increased recognition of these disorders, which we're mentioning as PANDAS and PANS. I'm going to let you define that and explain what the difference is. But there's also a lack of awareness and a lack of knowledge of who these kids are and what to do with them. So I'm going to give you the floor. I'm going to let you take over and just start out by defining for me what the difference between PANDAS and PANS are, just from the very beginning.
All right, well, let me start with saying that PANDAS is related to streptococcal infection.
Mm-hmm.
Strep is a pathogen, a bacteria that only infects humans. Most people have had it in their lives.
Mm-hmm.
And it's a killer in areas where people have not gotten treatment. They can have heart disease from it. You may have heard of rheumatic heart disease. Well, we have a difficult relationship with strep. Some people, most people not now, but some people, immune system reacts after a strep infection, like we're talking about now with the new COVID immune wave that might come after a viral infection. But the body's immune system, it gets misdirected and cross-reacts to affect part of the brain that is like a railway station of the brain in the basal ganglia. It's smack dab in the middle of the brain, and many neurons go through it, controlling things about movement, emotion, attention, thinking. And so when that gets inflamed, because we've had strep infection, then all sorts of seemingly unrelated problems can come at once. It's interesting that way. PANDAS is defined by no blood test, unfortunately. We'd love to have an easy way to say, bang, you have that. Well, we'd never like to say you have that. But if you do have it, we'd like to be able to identify it. It's defined by the course. How does it start? Well, how does it go? And by what symptoms people will get. So the course is, you have someone who has been fine, just a regular child, not really any troubles, classically and by definition, and suddenly, overnight, like they're hit by lightning, they change. Parents talk about the kids changing their personalities. They went to school one way, they came home from school a different way. They went to bed one way, they woke up in the morning the other way. And so it comes on, bam, just like that. That really distinguishes PANS and PANDAS. PANS, I'll just say, is an umbrella term over over very similar, I'm going to group them together for all purposes here. But instead of strep, I believe that maybe people who have had strep before, another day might get influenza or walking pneumonia, mycoplasma pneumonia, and then they suddenly can get this onset of symptoms, seemingly, some of them unrelated, but they are, if you think about that it's related to inflammation in the basal ganglia and thalamus, but mostly in the basal ganglia in terms of what we've learned.
I'm sorry, did you say that first they had to have strep and then the other infections, or are these infections able to trigger that independently?
Well, that's not really known. It's not really known. So I can't say definitively. I wonder about that. But we do know that, well, I'll stop with there. So when I say PANS, I am talking about one of these lightning-like starts that happen and you didn't find strep. That's the only difference. If it's strep, you find you say PANDAS if you found the strep, PANS if you didn't. So first I'm just talking about how it comes on, and it tends to get better over several months. But if you come upon another infection, you get reinfected with strep or maybe something else, bam, you can become symptomatic again. So if you drew on a graph what it looks like, it would look like a sawtooth. You get sick abruptly and then gradually can get better. And then, you get sick abruptly worse and gradually get better.
Now these things you see, these symptoms are what?
All right. The cardinal #1 main symptom is obsessive compulsive disorder. And that's how I got into this topic, because I ran the OCD disorder clinic for years. And I noticed that some of my OCD patients had a sudden onset, and if they went and got treated for their sinusitis, they got better, which was a very strange thing to see. Patients I'd worked with for a long time trying to treat them with medications, psychiatric medications, and cognitive behavior therapy, which are important treatments and indicated for OCD. But it was very unusual that some of these kids could get better in a few days or weeks. So, of course, this was intriguing. I'd like to get to the bottom of things. So OCD is a problem where people get thoughts stuck on their head. I don't know if you've gotten a song stuck in your head. That would be much better than having an obsession stuck in your head, but it's relentless. And the way OCD works is one's brain says in OCD, well, if you just do this thing, the obsession will go away. Those annoying, frightening, usually thoughts. And it might be by tapping something. It might be by washing your hands. It might be by avoiding taking a shower. It's very idiosyncratic. I've never met two people with identical OCD, really, over many years.
Right. I want to make the point here that when you say OCD and you found the cause seems to be underlying PANS or PANDAS, what percentage would you say were those of your overall population of OCD? I'm trying to put it in perspective.
Thank you. I want to be really clear about this. We only have one study telling us that, because when you open a clinic, you're not getting the general population, you're getting people who are coming to your clinic. But a Canadian clinic where they have socialized medicine and they keep good records on everyone, found that in a general clinic, they looked at all the kids that came in with OCD, and that's about 1 to 2, maybe 3% of kids. Of those, 5% had probably from PANS or PANDAS. So if you are good at decimal points, or if you're not, 5% of 1% is a small number. It's a rare disease, but it's a dramatic disease, and part of the drama of it is you can treat a mental illness in a very different way than you might have thought. with antibiotics treating a strep infection and with anti-inflammatories, but I'll get to that. So I want to come back to the symptoms. OCD is the main symptom. There's three possibilities of like the main, you must have this to get the label if you want the label, but at any rate, OCD or tics, motor tics, or food refusal, people who don't eat. And it could look in the way like anorexia nervosa. Anorexia just means you're not eating. But people with PANS might not eat because of textures, smells, OCD thoughts about things being poisoned, contaminated, outdated. But they can be just as restrictive as someone with anorexia nervosa, and they may need hospitalization for their fluid and food restriction.
As you're talking about avoidant restrictive food intake disorder, or ARFID, which is relatively new classification of an eating disorder.
That's exactly right, ARFID. So ARFID, OCD, or motor tics. And then you have to have, for the definition, the diagnosis, a couple of these symptoms. Bedwetting that you didn't have before, or urinary frequency. And it's not about OCD. It's about a sensation that they have to go to the bathroom. It could be 5, 6, 7 times an hour. Or people who have been dry for a long time, children, start wetting the bed. Another kind of non-intuitive finding is that people can have deterioration in their handwriting. If you take handwriting samples before they were ill and after they had PANS onset, you often can see a dramatic worsening in their penmanship. They get a panoply of psychiatric symptoms. They can get mood symptoms, including very uncharacteristic rage attacks, where your previously lovely child would suddenly fly into a rage, might kick, bite, scream, say words you never knew they knew. This could last for hours, and then afterwards, they may not remember it, or they may say, I don't have any idea why I did that. I'm so sorry. It feels like some sort of, comes on like a thunderstorm, a sudden summer thunderstorm, and goes away as quickly.
It's like rage attacks you're talking about.
Yes, a rage attack.
Right, but I'm going to point out that everything you're saying, all of these symptoms are not in and of themselves diagnostic, and they're more commonly going to have other causes. Am I correct? Just so people don't hear and they say, oh, well, my child has the sudden onset of frequent urination. Frequent urination in a preschool child is not an uncommon thing by itself.
Right, and it needs to, they need to go to their pediatrician and find out what they can find out. Right. In isolation, any of these symptoms, each of these symptoms alone, you must go check it out. But if you see suddenly this constellation, and if I could show you a picture, I would show you. I love that one. The Big Dipper, because it's kind of like a pan, and I'm just corny, but
I didn't know that.
But they have OCD, tics, food refusal, moodiness, rage attacks, bedwetting, accidents, like urinary accidents, ADHD. Their handwriting changes. They're anxious and they will just glue themselves to their mother's legs or father's legs. And then they want to sleep with them, and then they might wet the bed. And they also have very restless sleep. Many of them have periodic, I don't mean that, they have REM motor behavior disorder where they move in their sleep, which is a sign of basal ganglia pathology. And it's also seen in Parkinson's, and I'm not saying we know anything about the relationship with that.
You mean like periodic leg movements?
Well, it's like that, but they are running, they're hitting things,
Wow.
Most of the patients who have gotten sleep studies in our group have had them, and they found that at NIH too.
Wow. I mean, a lot of this, I'm just, going to keep saying what I know from my end as a pediatrician. Even all of that together, we do see with children with ADHD and autism, but the difference is it doesn't come out of the blue.
It's so important that this sudden onset, which I keep saying, that's what defines it. It's not PANS or PANDAS. if it doesn't have a sudden onset,
Mm-hmm.
improve over time, and get worse again when you get sick. I mean, everyone feels worse when they're sick. They could be moody. In fact, in autism, if someone's acting up, you look in their ears, right?
Right.
Make sure they don't have an ear infection.
Right.
Being sick, that's a whole thing. And maybe there's sick behavior and sick feelings that you can see partly in things like chronic fatigue. We don't understand completely.
Mm-hmm.
But at any rate, this is different than just a rage attack. It's important if someone comes in with these symptoms to work them up medically and think
Mm-hmm.
about things psychiatrically. If someone has been abused, you could suddenly see a marked change in behaviors.
Mm-hmm.
You could have urinary symptoms. I mean, it's important to keep your differential wide, but if you see this constellation of a numerous symptoms and different kind of systems even, that's something you should really look for. Is this PANS or PANDAS?
So say you are a pediatrician like me, very busy. What do you do next? You see the constellation. Now what?
Well, some of the things you can do, I'm going to limit this to being very concrete to start out. Lots of things you can do are bread and butter pediatrics. So since strep is the main culprit,
Mm-hmm.
make sure you have a good look and a culture technique that makes people gag,
Mm-hmm.
right? And we always ask about itchy bottoms. The kids have itchy bottoms or red circles around their bottoms with perianal strep.
Mm-hmm.
Is the girlfriend someone who constantly gets strep? Of the teenage kid that has this, we look at the whole family, we look at contacts. So we just have to get strep out of the picture.
Mm-hmm.
And it
Do you
could
do a
be
strep and a strep culture? Do you do other tests like the blood test for history of strep, like the ASLO?
We do ASO and anti-DNase B,
Mm-hmm.
but it's not diagnostic. It's not a marker for PANS and PANDAS. So some people might come in and say, oh, we had elevated ASO and anti-DNase B, this must be PANDAS. Well, most kids will have evidence. These are evident antibodies that show you have been acquainted with strep before. Most people have had it. In fact, some of our kids with terrible PANS don't even make those antibodies because of some sort of immune dysfunction they have. Yeah.
Wow.
So to have it be helpful, you have to have at least 2 sets of ASO or anti-DNase B strep titers with some time in between. If they're going up or going down, it tells you then that there's been an encounter with strep. So step number 1, rule out strep. If you don't see anything to indicate it, is there sinusitis? Is there an ear infection? Is there evidence of mycoplasma pneumonia? Any other, just a regular, that's just bread and butter pediatrics. And so you would treat anything that you see and work up anything that you suspect. Of course, if they have frequent urination, you will order a urinalysis, but it wouldn't be abnormal if they had PANS and PANDAS. Other bread and butter things. If you feel confident of the diagnosis and you're comfortable with it, use of NSAIDs and use of steroids are things that have been shown to decrease in retrospective reviews.
Right. So when you say NSAIDs, you mean like Motrin, ibuprofen, that category?
Yeah, we use naproxen more because it's twice a day. And to really do a good job with ibuprofen, it's 3 or 4 times a day, which is very difficult. And then what if the child doesn't want to swallow pills? However, I think the liquid naproxen tastes worse than the liquid ibuprofen. So there's a trade-off. So that's off the grocery shelf, and you just use the dosage as you would for anything.
And for oral steroids, you use?
Like if someone fell into
prednisone?
Yeah, you could use that. Like someone fell into the poison oak or ivy, wherever you live, that kind of a thing.
You mean like a taper? You mean like a higher dose where you taper it off, not like when we give it for asthma, we give usually just a few days. But for poison ivy or poison oak, when you're worried about, it coming back, it rebounding, you do a longer course, a higher dose and a longer course with a taper.
Well, now we're talking where the edge of knowledge is.
Mm-hmm.
In this disorder, we don't have good evidence for what would be best.
Mm-hmm.
A short burst. Some people who are quite severe, if they have like life-threatening illness, meaning they're jumping out of cars and feeling suicidal, we may give them IV steroids, which of course is very limited by, you have to be very careful because the psychiatric symptoms can also become on steroids, colloquially.
Roid rage, right? Roid rage, right?
Yes. So you do that quite carefully. People hear about IVIG, and I don't blame them for saying, "Oh, my child has PANS or PANDAS, I think, and they need IVIG right now." The studies have been equivocal. It's undeniable that some cases get better with it, but studies still need to be done more. And insurance companies in most places will not allow it. So in our area, people wait maybe 6 months to get IVIG, which is really not what you're talking about when a child comes into your office or the emergency room. It's not what you can easily reach for.
Now, IVIG is not for the milder cases, correct?
Right.
I like on the PANDAS Physician Network, what I do really like about that site, I mean, I do have the caveat about the list of doctors and a social worker there who doesn't mean to be there. The information is really, really excellent. And I recommend that, any physician who wants to learn more beyond this talk, go check it out. I love how it's divided into mild and moderate and severe. And you're not recommending IVIG for the milder. I don't know if you want to go into the differential categories.
I would say that if you're heading toward IVIG, I believe you should be consulting a rheumatologist, immunologist, which ID specialist, wherever your scent goes, and whoever is around you that will collaborate with you in that way. Back to the workup that you could do in your own office, we sometimes can frequently find immune dysregulation. We have a small handful of patients with immune deficiency, CVID. We have many patients with lots of allergies. We have, one of the ways we direct our treatment is we find, and usually it's after the flare, I would call right after you get the big onset. After the flare, you find arthritis and emphasitis. And so
emphasitis means inflammation of
the connective tissue around the joints. And that kind of justifies, it's an indication for using anti-inflammatories when you don't have the evidence, because the studies haven't been done about PANS and PANDAS. So,
why are we still here? I mean, wasn't this diagnosis made a long time ago?
Well, Sydenham chorea is a very close cousin to PANS and PANDAS.
I mean, I've seen that. It was not controversial at all.
No, and it's very strange because people say, well, that's from strep, but the strep could be half a year beforehand. So, yeah, it's right. So Sydenham chorea is not dissimilar. Why was I saying that?
It's the same basal ganglia involvement.
Yeah, right.
Now, with
Sydenham's, they also have OCD and terrible temper tantrums.
And with Sydenham's chorea, because I haven't seen it in a long time, was that associated with inadequate strep treatment, or it had nothing to do with the effectiveness? I'm going to get to PANS and PANDAS, whether that's related to ineffective treatment or inadequate or not treating.
I believe, but this is not my expertise in particular, but when I read about Sydenham chorea, I'm reading people about writing it up currently in areas where people are not accessing healthcare as easily as we do. So that I believe it has to do with undertreated strep. just like rheumatic heart disorder.
Now, do you think that PANDAS is also related to undertreated strep?
Well, yeah. I mean, if you have PANDAS, you need to be, and you have a strep infection, you must be treated for
Right,
strep.
it will exacerbate it. But what I'm asking, and I don't know if you know this, but is untreated strep the cause of PANDAS, or could PANDAS happen regardless? Like there are certain disorders, like we know rheumatic heart disease is related to untreated strep, but we know that the kidney infection, right, glomerulonephritis, occurs regardless of how well strep is treated. It's, seems to be,
Right.
maybe an immune response. So if this is an immune response, it could be unrelated to treatment or it could be related. Do we know?
Well, I mean, this is very tautologic, but by definition, the only way you can say you have PANDAS is there's a strep
right.
Infection involved.
That wasn't treated at that moment.
Right. And then PANS was introduced because we have kids that just look a lot like PANDAS, but they didn't find a strep infection.
I mean, it could be another infection that does the same thing.
Yep.
So why do we still have this as such a controversial, and poorly delineated disorder? I hope it's okay that I'm asking this. I know you're the head of a clinic. It's just here on Long Island.
I'll tell you my opinion, because it's my opinion, right? I don't know the reason, but of course I've thought about this. Around the same time, kind of roughly, that people were thinking more and more about PANS and PANDAS. People are also thinking about superbugs, meaning bacteria who are resistant to our antibiotics. And I believe, and you're a pediatrician and I'm not, that the APA was recommending less active antibiotic use and some more wait and see, like for sinusitis and otitis.
You mean the American Academy of Pediatrics?
Yes, AAP, sorry.
It's okay. APA, I think it's American Psychiatric Association. That's why I got confused. Yes, the AAP was pulling back on antibiotics. And by the way, there are people who are more into natural medicine who would prefer not to treat their children's strep with antibiotics or get tested too much. And I wonder if that population has more of these PANDAS.
Well, in many people, they have strep and they never know it and it goes away. In my youth, it felt like you had glass in the back of your throat when you had strep, but now you can get it and not know it.
You could be a carrier, right?
Yeah.
Like an asymptomatic carrier.
Yep. Or
I had strep for the first time like 2 summers ago and I was dying.
dying. I'm sorry.
That was awful.
As far as you know, it was the first time. But so there are people in the world, and maybe most people in the world could have a strep infection and not suffer bad effects. We are looking at HLA associations and finding that genetically, some people are, well, our population has some really concentrated populations within it that have the same HLA types, subtypes. And so for some people, maybe they get strep and it's not a bad consequence. For some people, it's a very bad thing to have strep and not get treated, because then, just like we're seeing in COVID, but not exactly the same symptoms, but the same mechanism, they get strep and then their body says, oh my gosh, we're firing up all the immune system, let's go. And they're getting brain inflammation. A lot of them get inflammation elsewhere too.
Right, it's like Crohn's disease where you have HLA, subtypes, or arthritis or other autoimmune disorders.
That's
so it makes sense that there's a certain population and you don't know who those are.
We have an overrepresentation of kids with psoriasis in their family, of spondyloarthropathy. So when you're saying it's untreated strep, I think you don't know who you're going to be.
Right, you might be fine
or not.
Right.
Yeah.
I mean, it makes sense to treat it.
I believe it should be treated.
I mean, it should be treated anyway. We know that rheumatic heart disease can result from that untreated strep, and so maybe this too.
If you go to graveyards and look at
Right.
old headstones, you'll see that also scarlet fever, which is a streptococcal associated trouble, just wiped out so many little babies,
Right.
little kids, toddlers. Strep is a very destructive thing in some people.
Right. My first grade reader had a child with scarlet fever, and there was a sign, you know, quarantine. Right. You can't. Now we know all about quarantine, but
yeah.
So yeah, so that's a really good answer. I mean, there's a lot we have to know, but why is it so controversial? Why do people say, I don't believe that it even exists? Please help me with that.
Some people were afraid
Mm-hmm.
that if children came they were diagnosed with tics or OCD,
Mm-hmm.
they might not get appropriate treatment,
Mm-hmm.
which would be first cognitive behavior therapy
Mm-hmm.
or habit reversal therapy, and if need be, psychiatric medicine.
Mm-hmm.
People worried children will get unnecessary workups, medical workups. People worried other people would throw around antibiotics, making our resistant bacteria situation worse. This is what I believe.
It makes sense.
In life, there always are politics.
Mm-hmm.
And so can't really speak to that.
I mean, I'm not asking you to.
Yeah,
I'm not asking you to. You know, we can all fill in the gaps in our mind. But I think it's an important point that you're making, that just because you have a PANS or PANDA diagnosis does not mean you don't treat the symptoms with appropriate standard of care, which can include cognitive behavior therapy, habit reversal therapy for tics, which is really a whole other topic that we're not going to go into. But I think people often become very black and white. You know, they get the diagnosis, they go on antibiotics, they worry about strep every time, and that's it, done. And I think a lot of these disorders are very complex. It can be hard to get a diagnosis with some of these disorders.
I'll tell you about my very wonderful fancy place. I work fancy in that we have collaboration live. I'm a child psychiatrist and I sit in the office with a pediatrician for every visit, or a primary care nurse practitioner. And we have a rheumatologist we can just pull into the room. The really hard part about this is the kids can fall through the cracks. I'll not speak for you, but I'm guessing most pediatricians, if they have a child with a rage attack in their office, that's not what over time, of course, you become experienced around a lot of children.
We can handle anything.
Right, but it's not your typical bailiwick.
Right.
And certainly child psychiatrists, psychologists, social workers are not generally pulling out their diagnostic tools for sore throat. They're not prescribing antibiotics. Well, these kids have a psychiatric illness, generally psychiatric symptoms, caused by medical problems, infection and inflammation. Where do they go? So in our clinic, and I just have to say before I go further, our clinic is a research clinic. We hardly take anybody, and only people who live in the counties right around us and have lived there for years.
Right, we're kind of devastated by that, but okay.
I'm sorry.
We can't send to you, not even by telehealth. We got it.
I know, but we're really trying to get to the bottom of it, and I think we're making progress. And I can't talk about it, not because, I just don't want to be improper talking about unpublished things, but we are making progress. I'm not saying we have the answer, but we thought about it. We talked to our ethics board. And they said, listen, when we started our heart transplant service, we had to turn away people too, and that was terrible. This is terrible. I am so glad I don't have to be the one receiving the request for service, which is why we worked on the guidelines. Where was I going with this? Oh, because you need a multidisciplinary team.
Ideally, right. You need a multidisciplinary team, ideally. And this is a classic example of a mind-body disorder.
Yeah. So or
multidisciplinary would be ideal, but you know what I say to people, because I don't want to have people listen to this and say, oh, we'll have to move to California and move to near Stanford and we'll have to establish residency. You don't ever want perfect to be the enemy of the good as you're going to get, number one. Number two, I am a very big big proponent of build your team, and you are your child's best advocate. So when talking to parents, and people know I'm on this podcast, I'm very open. I have a daughter on the autism spectrum. She's had other issues. You are your child's best advocate. We are dealing with a disorder that we're still learning as we go along. And now that we're in COVID, everybody should understand this. Even physicians should have the humility to understand that we're dealing with something that people are living with right now that we don't fully understand. And your patient in front of you, you have to help. So even if you can't do it yourself, and maybe you shouldn't, right? Especially if you're a particularly busy pediatrician, you're not a multidisciplinary team, you're one person. But get a relationship with a neurologist, get a relationship with an ID, get infectious disease, get a relationship with a rheumatologist, and build your team for your patient. And as the parent, you can ask for this. You can say,
Yes.
this specialist works for me, this one does not. Because I'll tell you, the next problem is going to be when we don't have access to appropriate care, people become vulnerable to people who are not necessarily intentionally taking advantage, but jumping into the empty void. Okay.
Yeah.
And that would be the category of who not to go to. And we're not going to point fingers at any particular person, but I always tell people, when you hear that something cures everything, it probably cures nothing. You know, when you're told, oh, PANDAS, we have the magic cure for PANDAS, right? It's just come to us and we'll give you the magic cure. What would you say to that? I mean, I know I would say, go away. Don't avoid.
If something's too good to be true, it's not true.
Right. Right.
A, nobody knows exactly what to do. B, it takes a multidisciplinary team. And I run groups, and we're studying it too, for PTSD groups for parents of kids with PANS and PANDAS, because trying to get someone to believe you, trying to get someone into care is often terrible. I tell parents, it shouldn't be this way, but you have the most skin in the game, and you're going to have to be the case manager. And you're going to have to help your doctors communicate with each other by hook or crook, however you can figure out. You need a huge white notebook full of all the records, or virtual, that's now electronic, but you're going to have to be the one, oh no, they should have the medical records. They might not. And guess what? They don't have time to read them necessarily. If you give them a, if you give them that thick white, they're not going to. It's really up to you to communicate well, try to help your pediatrician pull together a team.
Right, and have reasonable expectations. And the other thing I'm going to say as a pediatrician is, I think parent support groups are wonderful, but they're not physicians. They're not diagnosticians. And I will have to say, I've been in support groups where I didn't belong. Because my daughter didn't have, I'm just talking about because the issue for a doctor is a parent comes in and says, my child has PANDAS. Who made the diagnosis? Right? Their friend, their support group, or whatever. Other people told them, they looked at that constellation in their way, and maybe the child does, or maybe the child doesn't.
Yeah, right? And there's things that we don't have labels for yet. This is not, I don't like this phrase, but I don't have a better one. If you have a better one, let me learn it. When a new diagnosis or a new treatment comes out, people come out of the woodwork, and I don't like that. But anyway, it's just they're worms or something, but I don't like it. But they say, oh my gosh, what if my child, odd OCD behavior, and they are clingy. What if this is from PANS and PANDAS? And what if just giving them this or this or this would dramatically change them? I don't blame anybody for looking for a new answer. But it's there. We don't know enough yet. We know we made these. I was in making the diagnostic criteria. We made them as narrow as possible, so that when we did our research, we were all going to research the same thing as much as we could. There might be people who get OCD, sick, and one of those symptoms. Who are they? I don't know yet.
Right, they may be part of the spectrum. You may just be looking at the tip of the iceberg in order to study the pure form of it.
You've got it.
Right, but the flip side, though, is that there are parents, particularly of children on the autism spectrum. I mean, any
Mm-hmm.
pediatrician can tell you that the majority of the kids that we see coming in saying, I think my child has PANDAS, actually have autism. And when you described all of those things, it's not uncommon for kids on the spectrum to have all of those things. OCD is very common, separation fears, eating disorder, all of these things, restrictive eating, are super common for kids on the spectrum, which unfortunately is a relatively common diagnosis now. And
Yeah.
I've actually been told, one parent actually legitimately straight out said to me, why would anyone want that diagnosis when there's no cure for it and there's a cure for PANDAS? And I'm like, either your child has the PANDAS or PANS, or they don't. It's not like you're diagnosis shopping here. Even with PANDAS and PANS, you can correct me, but there's not a magic cure for that either.
No, there's not. It's just you're more vigilant about infection.
Mm-hmm.
Right. And if you see a change in behavior, you should, I'm talking about autism now, but anybody, a marked change in behavior, find out why, right?
Mm-hmm.
Is someone at school being mean to them? Are they not getting along with their aide? Whatever it is, do they have a throat infection? Do they have perianal strep?
Right. And in all fairness, children on the spectrum can have PANS and PANDAS. And
yes,
that's always been a problem of children on the spectrum getting, okay, you're on the spectrum. That's it. That's your diagnosis. You're done. You have nothing else. And especially for children who are nonverbal, you could see how a strep infection could be missed. So of course, there's going to be an overlap. But we have to be honest. We have to be honest as parents. We have to be honest, as physicians, I believe. In terms of, making sure that you have the right diagnosis. But I think also I'm going to just beg again and put my mommy hat back on and say, beg again to doctors, listen to parents. Because it's so frustrating. You mentioned before how they have a PTSD support group.
Yeah, it's a therapy group. We're teaching them cognitive for themselves to treat their own symptoms, because if mama's not happy, nobody's happy, right?
Right, but why do they have those symptoms? Because no one believed them, right? Because they had a whole diagnostic, journey just to get to someone who believed them.
Right, and these are all people who made it to our clinic.
Right.
And had very stringent criteria to get in because of diagnostic criteria. And they still are very, very traumatized.
Right, right. So I think this was really, really helpful. I think it's a nice overview. I'm going to mention again the PANDAS Physician Network as a resource outside of the clinician list for that, and build your team in terms of getting specialists on board as appropriate if you think that your patient meets these criteria. And for parents, what would you recommend as a resource for them?
The National Institute of Mental Health has mentions of it. Stanford's website for PANS, we have links to lots and lots of material. Those are reasonable ones. I think it's basic, but I think the CME activity that I put out is a good starter for people. It goes through a case and how to work it out and treat initially.
No, I think that that's really excellent and really helpful. And I thank you so, so much for doing this with me. I really appreciate it.
You're welcome. You're very welcome. It's been a pleasure talking to you.
Thank you. You too.
Mm-hmm.